Hello friends, I am Dr. Poonam Kela, working as Assistant Professor at Modern College of Pharmacy, Nigdi. Today I am going to conduct a lecture on Type 2 Diabetes Mellitus. DM is defined as heterogeneous metabolic disorder characterized by common features of chronic hyperglycemia with disturbance of carbohydrate, fat and protein metabolism. Basically it is divided into two types, Type 1 and Type 2 DM. So let's see Type 1. So first I will summarize all types of DM. In that we will see first Type 1 DM constitute about 10% causes of DM, previously termed as juvenile onset diabetes. As it is occur in younger age, it is called insulin dependent DM because it requires insulin. In new classification, neither age nor insulin dependence are considered as absolute criteria. It is subdivided into two types, that is 1A and 1B. In 1A, it is called as immune mediated, which is characterized by autoimmune destructions of beta cells, which usually leads to insulin deficiency. And 1B is idiopathic, characterized by insulin deficiency with tendency to develop ketosis, but these patients are negative for autoimmune marks. Then type 2 DM comprises about 80% causes of DM, previously called maturity onset diabetes, also called as non-insulin dependent DM of obese and non-obese type, predominantly affect older people. Then another type is specific etiological type of DM. 10% of DM have known specific etiological defect, genetic defect of beta cell function, genetic defect in insulin action, disease of exocrine pancreas, infection, genetic syndrome. And the last is gestational DM. It is occur in pregnant lady. 4% of pregnant women develop DM due to metabolic changes. So we will see the complication of diabetes. There are two types of complication, acute metabolic complication and late systemic complication. In acute metabolic complication, it is diabetic ketoacidosis, DKA, hyperosmolar, hyperglycemic, non-ketotic coma and hypoglycemia. In late systemic complication, it is atherosclerosis, diabetic microangiopathy, diabetic nephropathy, diabetic neuropathy, diabetic retinopathy and infection. So we will see one by one. In diabetic ketoacidosis, insulin deficiency causes lipolysis of adipose tissue, which leads to release of free fatty acid into plasma. Oxidation by acetyl-CoA in liver leads to formation of ketone bodies. The urinary excretion of ketone bodies is prevented due to dehydration and causes systemic metabolic ketoacidosis. The signs and symptoms of ketoacidosis is anorexia, nausea, vomiting, deep and fast breathing, mental confusion and coma. The next is hyperosmolar, hyperglycemic non-ketotic coma, that is HHS. Severe dehydration result from hyperglycemic diuresis, leads to blood sugar is extremely high, plasma osmolarity is high, which leads to high viscosity of blood and ultimately thrombosis and bleeding complication get occur. The next is hypoglycemia. Hypoglycemic episode may develop in patient of type 1 DM. It may result from excessive administration of insulin, missing a meal or due to stress. Hypoglycemia episodes are harmful as they reduce permanent brain damage, rebound hyperglycemia, so-called Somogis effect. Next is atherosclerosis. DM of both type 1 and type 2 accelerates the development of atherosclerosis. The causes for this accelerated atherosclerosis process is not known, but possible contributory factors are hyperlipidemia, reduced HDL level, non-enzymatic glycosylation, increased platelet adhesiveness, obesity, associated hypertension in diabetes. The next one is diabetic microangiopathy. Microangiopathy of diabetes is characterized by basement membrane thickening of small blood vessels and capillaries of different organ and tissue such as skin, skeletal muscle, eye and kidney. Similar type of basement membrane like material is also deposited in non-vascular tissue such as peripheral nerve, renal tubule and Bowman's capsule. Diabetic nephropathy, 4 types of diabetic nephropathy is seen. In that, first is diabetic glomerulosclerosis, vascular lesion, diabetic pyelonephritis and necrotizing renal papillitis, tubular lesions, that is Epstein lesions. Next is diabetic neuropathy. Diabetic neuropathy may affect all parts of the nervous system, such as symmetric peripheral neuropathy is most characteristic features of this. Then next is diabetic retinopathy. Diabetic retinopathy is a leading cause of blindness. There are two types of lesions involving retinal vessels, background and proliferatives. Diabetes also predisposes the patient to early development of cataract and glaucoma. Then next is infection. Diabetics have enhanced susceptibility of various infections such as tuberculosis, pneumonias, pyelonephritis, otitis, carbuncles and diabetic ulcers. This could be due to various factors such as impaired leukocyte function, reduced cellular immunity, poor blood supply due to vascular involvement and hyperglycemia. Here I have shown some pictures which shows tuberculosis, pneumonia, diabetic foot ulcer, that carbuncles. Now we will move toward the diagnosis. So the main cheap and convenient test for the diagnosis of DM is urine test. Urine test may be false positive or false negative. Urine is tested for presence of glucose and ketones. Glucosuria is mainly performed with the help of Benedict qualitative test. More sensitive and glucose specific test is dipstick method. Renal glucosuria after diabetes. The next most common cause of glucosuria is the reduced renal threshold for glucose. The next is elementary glucosuria, a rapid and transitory rise in blood glucose level above the normal renal threshold may occur in some individuals after a meal. This type of response to meal is called lag storage curve, or more appropriately elementary glucosuria. Then ketonuria. Tests for ketone bodies in the urine are required for assessing the severity of diabetes and not for diagnosis of diabetes. However, if both glucosuria and ketonuria are present, diagnosis of diabetes is almost certain. Rothera's test and strip test are the conveniently performed for detection of ketonuria. The next is single blood sugar estimation. Foligno method for measurement of all reducing substance in the blood, including glucose. A grossly elevated single determination of plasma glucose may be sufficient to make the diagnosis of diabetes. A fasting plasma glucose value above 126 mg per dl is certainly indicative of diabetes. Then third one is screening by fasting glucose test. In that, fasting plasma glucose determination is a screening test for DM2. It is recommended that all individuals above 45 years of age must undergo screening fasting glucose test every 3 years. Many of the cases meeting the current criteria of DM are asymptomatic and do not know that they have the disorder. Studies have shown that type 2 DM may be present for about 10 years before symptomatic disease appear. About half the cases of type 2 DM have some diabetic related complications at the time of diagnosis. The course of disease is favorable altruist, which is responsible for the diagnosis of DM. In that, first one is glycosylated hemoglobin, that is HbA1c. Measurement of blood glucose level in diabetes suffer from variation due to dietary intake of the previous day. Then glycated albumin. This is used to monitor degree of hyperglycemia during previous 1 to 2 weeks when HbA1c cannot be used. Then next is extended GTT. The oral GTT is extended to 3 to 4 hours for appearance of symptoms of hyperglycemia. It is useful test in case of reactive hypoglycemia of early diabetes. Then intravenous GTT. This test is performed in person who have intestinal malabsorption or in post-gastrectomy cases. Then cortisone primed GTT. This provocative test is useful investigative aid in cases of potential diabetics. Then insulin assay. Plasma insulin can be measured by radio immunoassay and by ELISA. Then pro-insulin assay is included in immunoassay of insulin. Normally it is less than 20% of total insulin. Then next is C-peptide assay. This test is more sensitive than insulin assay because its level are not affected by insulin therapy. Then next is screening of diabetes associated complications. Besides making the diagnosis of DM based on the defined criteria, screening tests are also done for associated complication. In that, microalbuminuria, dyslipidemia, thyroid dysfunction test should be performed. Now we will see the oral anti-diabetic therapy. There are currently 4 classes of oral anti-diabetic therapy. In that, first one is bigunate, second is sulfonylureas, third is non-sulfonylureas. The second category is divided into sulfonylureas and non-sulfonylureas. The third is alpha glucosidase inhibitor, and fourth is thiazolidinediones, that is TZDs. Here I have shown diabetes management algorithm. If the person is suffering from type 2 DM, then at first level we have to maintain his diet and physical activity. If he get relief from this, then it is successful. There is no need of any pharmacological therapy. But if it is fail, then there are 2 categories. If the patient is obese and another one is non-obese. So in obese we have to advise patient to take metformin, acarbose or TZDs, and in non-obese metformin or insulin. If the treatment is successful, the blood glucose level decreases, then we have to continue this therapy. But if again the therapy is fail, then we have to add some other drugs. So in obese we have to add insulin, and in non-obese we have to add TZDs and acarbose. If again the therapy is successful, then we can continue the therapy. But if there is again failure of therapy, then we have to add insulin, and then we have to adjust the dose according to the glucose level. Now, here I have summarized some oral anti-diabetic drug with their brand name and with their mechanism of action. You have to summarize this and mug up this all. Now here, the glycemic management of type 2 DM. The patient with type 2 DM should advise medical nutrition therapy, increase physical activity and weight loss with metformin. But if the patient does not get relief, then we have to give combination therapy, in that metformin plus second agent. Again, if the treatment is fail, then we have to add combination therapy with metformin plus 2 other agents, and at the end we have to add insulin plus metformin if the patient does not get relief from the metformin plus 2 other agents. These are the reference. Thank you so much for listening me.